Okay, thank you so much. May I say a very big welcome to all great participants from Africa. Our session, breakout session 1C, is going to be considering the topic, research approaches to assess impact and quality improvement in health education. My name is Prisca Adejumo. I'm from Nigeria. And my partner is Professor Midion, Mapfumo, Chidzonga. We are the moderators for this session. I just want to introduce the three of the 5 speakers, while my partner will introduce to us the remaining 2 speakers. The first presenter is Johnston, who will be speaking with us on the topic, cluster randomized control trial of a community-based mobile video breastfeeding intervention in Khayelitsha, South Africa. The second speaker is Jennifer Jones. He will be speaking with us on investigating the role of certification in massive open online course, enrollment among healthcare workers. While the third speaker is Amin Elias, and the title is Transitioning Interdisciplinary Education for HIV from in-person to e-learning. I'm going to hand over to my partner, the co-moderator, Professor, to take over the introduction of the next 2 speakers. Over to you, Professor Midion Mapfumo Chidzonga. Professor Midion, are you in?
Please, from our interface, I think Prof is not yet in.
Okay, let me introduce the remaining 2 speakers. Right. I apologize about that. The 2 of the 5 speakers that are yet to be introduced are Machoga P. Canario, who will be speaking with us on decision to delivery interval of emergency cesarean sections and the associated maternal and neonatal outcomes at Chika Level 5 Hospital. And the last but not the least, the 5th speaker is Adija Sembua. Will be speaking with us on Stripe HIV project experience during COVID-19 pandemic at Kilimanjaro Christian Medical University College. So these are our 5 distinguished speakers. Let me quickly address our dear participants for this day. We have Q&A section where we are to put in our questions, and the speakers will address them when we are done. Can I hand over now to the first speaker, Johnston, who will be talking to us on cluster randomized control trial of a community-based mobile video breastfeeding intervention in Khayelitsha, South Africa. Over to you, Johnston. Thank you.
Thank you so much. Sorry about that. Just joining. It's my pleasure to be here today. I hope you can hear me okay. My name is Jamie.
Absolutely.
Wonderful, thank you so much. My name is Jamie Johnston, and I'm the Research and Evaluation Lead for the Stanford Center for Health Education at Stanford University School of Medicine. And I'm actually joined today by my colleague who is based in Cape Town, Nopiwe Job, and I am so pleased that she will actually be joining to be able to present as well. I wondered if it might be possible for you to also add her as a panelist as well. This study is a collaboration of a number of different researchers at Stanford Medicine and the Heidelberg Institute for Global Health, as well as researchers at the University of Cape Town and Stellenbosch University. And we are so pleased to be able to share about the effectiveness of an intervention that we evaluated, looking at the use of mobile video-based education for community health workers and their clients on breastfeeding promotion and safe infant feeding practices. If Nopiwe is able to join as a panelist, I would actually love to hand it over to her to share more about the intervention, as she was actually leading the study in the field in South Africa. Is that possible?
Absolutely. Well, we have 10 minutes each for the presentation. So if you can manage that within the available 10 minutes, that's great.
We should be able to. And also, do you, let me see, I should probably be sharing my screen so that you can see the
Yes, please go ahead. Thank you.
Okay. Apologies for that. Yes.
No, that's fine. I can see your slide now.
Okay, great. And if Nopiwe is able to join, just quickly as we're having her join, just a quick outline of our presentation. We'll be going through the background of the study, our objectives, the intervention itself, and then our findings. And Nopiwe, are you there and able to join? Okay. Let's see. It sounds like I'm not sure who's hosting the meeting. Would it be possible to unmute Nopiwe Job to join the meeting as a panelist?
Afihet, kindly help the speaker to unmute the partner so that they can be together. Thank you.
So in the meantime, I can keep going so that we don't run out of time. But this study was really motivated because of the low breastfeeding rates in South Africa, and particularly in areas that are more under-resourced. There have been documented studies that the promotion of breastfeeding, and particularly exclusive breastfeeding in the early months, leads to better health outcomes for younger children and reduced infant mortality. This is one of the priorities of the South African National Department of Health. And there is also documented evidence that the work of community health workers in the community is a very strong path for promoting breastfeeding and safe infant feeding practices. At the same time, there's not much evidence about technology tools that can help aid community health workers in doing so. And so our study is really motivated by that fact that we want to understand how can we integrate digital health education tools to aid the work of community health workers in this work. And so our objective of the study was to establish the effectiveness of a community-based mobile video breastfeeding intervention, which we've termed the Polani movie intervention, for increasing exclusive breastfeeding, improving other infant feeding practices, and increasing others. I would love to hand it over to Nopiwe now, if you're there. I'm going to check just one more time.
Are we sure he or she is in?
She is. She's sending me messages on the side.
Okay.
Liz, what's the name again?
What's the name?
Nopiwe Job. Maybe I can.
Okay, Nopiwe. The name is on the chat.
Okay.
Nopiwe Job. If she's not in, can you kindly just go ahead because of time?
Go ahead. That's fine. So the intervention itself is a series of 2 to 5 minute teaching videos that we shared through an offline mobile app on tablets. And so these videos were actually available outside internet access. We are actually able to have community health workers be able to download and stream the videos on tablets so that they could take them into the field in areas where they don't have good internet access. And we implemented the intervention with a strong collaborating partner of ours, the Pilani Maternal Child Health and Nutrition Trust. And Pilani is a non-governmental community health organization that employs community health workers who are known as mentor mothers. You can see here on this slide, the 13 videos kind of walk through the motivations of breastfeeding, breastfeeding recommendations, education about kangaroo care, the challenges of breastfeeding, and also talking about unsafe feeding practices. Additionally, addressing breastfeeding with certain types of other settings and conditions, such as what to do if one is has HIV. And so moving on, our setting, we implemented the study in Khayelitsha in the Western Cape in the province of South Africa. And this is a high adversity peri-urban settlement area. And it's characterized by high infant mortality and low prevalence of exclusive breastfeeding compared to countrywide statistics. And this is an area that the Pilani community health workers, the mentor mothers, have been working for some time. The methods of our study are a stratified cluster randomized controlled trial. And so we randomized the intervention across 84 mentor mothers who, over the course of a year and a half, enrolled 1,502 pregnant mothers who were pregnant between 20 to 35 weeks over 1.5 years. The randomization was stratified by settlement type so that we could get a mix of environments where the clients were located. The trial was registered in advance, and our estimation strategy was an intention to treat at the mother level. And we used Poisson models at clustering standard errors at the mentor mother. And so just to reiterate, the treatment condition was one in which the mentor mothers were provided tablets and trained to use the videos as part of their standard face-to-face perinatal counseling. The control setting, mentor mothers were provided the exact same tablets, but did not have the video intervention and still carried out their standard face-to-face perinatal counseling. In addition, we conducted a qualitative study at the end of the intervention in order to try to understand more of what was happening from the experience of the clients, but also the mentor mother side. And so we conducted 26 in-depth interviews with mentor mothers from both the treatment and the control. Okay, so just to talk quickly through the intervention and the study, originally we had assessed 100 mentor mothers for eligibility, and 16 were excluded because of lack of experience. They had only been at the organization for less than 6 months. These mentor mothers enrolled clients over 1.5 years. And so we did finally hit a total of 1,502 clients into the study. These were balanced across the treatment and the control. So in the treatment mentor mothers enrolled 747 clients, and control enrolled 755. We did then lose a number of clients throughout following them throughout the study. So what we wanted to do, and
hello, Johnston.
Yes.
The PUA job is in, if you still want to hand over to her.
Okay. Yeah, why don't I, just because of the time, I will continue with this, but I would love NOPUA to add to the findings, and NOPUA also led the qualitative study.
Okay, so that's okay.
I'm very pleased that she'll be able to talk through those
That's results. Fine, go ahead, thank you.
Yes, so we did lose a number of clients in the study as we were continuing to follow them as their babies were born and aged up to 5 months. But that was balanced across the treatment and the control group. So we don't think that it compromised the study design in any way. Okay, so our primary outcomes that we registered were 2 outcomes, which we're calling short-term exclusive breastfeeding and long-term exclusive breastfeeding. We decided to follow up with the mothers when their babies were approximately 1 month of age to understand whether or not they had exclusively breastfed in the last 24 hours. We also followed up again with the exact same measure at 5 months of age to understand about whether or not mothers were exclusively breastfeeding. And we decided to use this as our primary measure, the 24-hour recall, because of the accuracy of the 24 hours as opposed to lifetime. However, we did, as secondary outcomes, also asked mothers whether or not they had exclusively breastfed their infants since birth, And at 5 months, we asked the same question. So we're calling these the since birth recall outcome measures. We also asked about the early initiation of breastfeeding and whether breastfeeding was tried within the first hour of life. We asked if there had been any breastfeeding that had been done at 1 month, any breastfeeding that had been done by 5 months, and whether or not the baby was bottle fed and the methods that were used for bottle feeding. And one of the reasons that we asked that is around the safety and hygiene of the use of bottles. So going to our findings of the randomized trial, here, just to start before we jump into the findings, are characteristics of the mentor mothers and the clients in the treatment and control. And I think the most important thing to note here is that these characteristics were balanced across the treatment and control groups. The mothers themselves were an average age of 26 years, ranging between 18 to nearly 50, 46, 48 years. The median number of previous children was 1, although there's a range of 0 to 6. So there were a fair number of mothers that this was their first child. And the gestational age of the babies at which they were enrolled were also balanced as well. So we're comparing like to like in our study. So jumping to our findings, the first thing that I want to point out before speaking more to the differences between the treatment and control is that what we observed, which was a bit of a surprise to us, was that the exclusive breastfeeding rates and the safe infant feeding practices were very high across both the treatment and control. So if you see here, the video intervention, we had exclusive breastfeeding, 24-hour recall was 68.8% at 1 month in the treatment and 73.9% in the control. So this was quite high. And we attribute this really to the strength of the mentor mothers and the training that they have already received. And this is not dissimilar to some of the previous years at the Polanyi, among Polanyi mentor mothers as well. So that's one thing we wanted to note. Moving to the next slide, I can show the risk ratios. And what we did observe is comparable rates across almost all of our measures and between the treatment and the control group. So the breastfeeding rates, the other feeding practices were statistically insignificant from one another between the treatment and control groups. So one difference that we did observe was that maternal knowledge, which we assessed with the mothers through a 15-point assessment at 1 and 5 months, was slightly higher among the treatment mothers at 1 month. So it was modest, but still significantly different. We also did a number of robustness checks and conducted multiple imputation and also controlled for baseline covariates to check the robustness of our results. And they all, these results were robust to all of those checks.
2 minutes more.
Oh, yes. So the last thing to note is that we also track the time that mentor mothers spent with clients. And what we observed was that the time between the mentor mothers, between the treatment and control mentor mothers was roughly the same, but we also tried to track the time that they were actually spending the videos. And what we observed was a substitution effect where mentor mothers were actually showing the videos to their clients, whereas in the control, they were not. So the video intervention was replacing some of the in-person counseling that was happening in these visits. I'm going to quickly turn it over now that I believe Nopiwe can talk as she led the qualitative follow-up study.
Thank you so much. I hope everyone can hear me. So yes, we conducted in-depth focus group discussions with mentor mothers, and we had 3 main findings to report from the discussions. If you could go to the next slide, Jamie. Thank you. So the 3 main findings we found was, number 1, that the videos actually worked in reducing the burden on the mentor mothers to perform 100% of the health counseling verbally. We see quotes there saying, I figured I could start completing what I needed to write in the folder while they are still watching the videos, because there's a lot of paperwork to do. I think this is a struggle that a lot of persons in health work, and particularly in public healthcare, can empathize with the amount of paperwork that still needs to be done. There was also a quote that we omitted here that says, even when I'm done, I have other things out of which they could learn. So that was very helpful. There were other things that the mentor mother left out, and it was good that they could find that in the video instead of needing to say it verbally. Let's move to the next slide. The second finding was that the mentor mothers felt that the videos increased the consistency of messaging across clients and improving general interest in infant feeding. So we'll read a quote there that said, when I switched on the videos, you would notice that even the one washing the dishes would be interested. You know, the screen is big and bright and it showed everything clearly because, you know, if they would even get a church to join, they're surrounding you, they want to watch, they are very interested, which is a struggle in any health education really, of maintaining interest and concentration of our clients for the important life-saving information we want to share with them. And number 3, let's go to the next slide, says, the mentor mothers felt that the messages presented in the videos underscored and legitimized their profession and advice in general. We know that mentor mothers or community health workers everywhere around the world have stigma attached to them because of their qualification, that they might not be real health workers. And we find a quote that says, the tablet means that you're educated and you have a reputable post at a reputable company. It had a beautiful effect on my job. Like when you educate and see the content in the videos, you know they are talking about something they can see in the videos, which adds weight. So it legitimized whatever they were sharing with their client.
Time up. Thank you so much. We have spent 10 minutes. If you can just paraphrase the discussion, just paraphrase it because the time is up.
No worries. So we conclude that increasing access to effective video health interventions could actually support community health workers and their communities of care by promoting life-saving behaviors such as exclusive breastfeeding. Finally, we say that with the proliferation of mobile technology, it is really our responsibility to explore alternative delivery channels for mobile video health interventions and to measure across these different channels the potential for these interventions to increase health access to health promotion and to support existing community health worker programs. Thank you very much.
Thank you so much, appreciate it. And the next speaker is Jennifer Jones, speaking on investigating the role of certification in massive open online course enrollment among healthcare workers. Over to you, Jennifer Jones. Please place your questions in the Q&A section. I'm searching so far, there's no question, but you can come up later at the end. Thank you. Go ahead, Jenny.
Hi, sorry, I was on mute. So hello, everyone. Can you hear me now?
Yes, we can hear you. You have 10 minutes. Thank you.
Thank you. So hello, everyone. Thank you for joining me today. My name is Jenny Jones. The abstract I'm presenting is investigating the role of certification in massive open online course enrollment among healthcare workers. So just a quick introduction. I'm currently a global health fellow in emergency medicine at Stanford University. I'm also studying for a master's degree in health professions education virtually through the University of Illinois at Chicago. Just briefly, an overview of what I'll be talking about for the next 10 minutes. So first, we'll define what a MOOC is, or Massive Open Online Course. Then I'll introduce the COVID-19 MOOC that was put together by my colleagues in emergency medicine at Stanford. Next, we'll delve into my work on determining motivations for course enrollment and course completion with some preliminary results. We'll discuss the comparative courses that were produced by the Open WHO and the data we plan to gather from this new collaboration. So massive open online courses are a relatively new concept in education. The first MOOC described in the literature was produced by professors at the University of Manitoba in 2008, and they engaged more than 2,000 students. But the MOOC that really put MOOCs on the map was an artificial intelligence MOOC developed by professors at Stanford University and MIT in 2011, so just 10 years ago. This course attracted more than 160,000 participants from 190 countries. So what exactly is a MOOC? Using an online platform, courses can be disseminated to massive populations of learners without the traditional geographic and institutional boundaries that have heretofore constricted educational programs. These courses are open to anyone without an application process or tuition requirement. Generally speaking, most MOOCs are self-paced and can be started at any time and completed over any time frame. MOOCs can and have been designed to teach a variety of topics, including healthcare, which has been increasing in popularity. So there are a lot of advantages to using MOOCs in health professions education, much of which can be described by conceptual frameworks of adult learning theory. But I'd really like to highlight the use of MOOCs for just-in-time training during public health emergencies. The WHO has previously produced this type of training for pandemics like Zika, Ebola, and dengue, and now most prominently COVID-19. In terms of MOOCs in general, the cited completion rates are generally quite low, in the range of 5 to 10% of those who enroll actually complete the course. Specific to global dissemination of MOOCs, there are barriers in access due to their reliance on advanced technology that requires users to not only be proficient in using computers and the internet, but also have reliable access to these resources. In August of 2020, some of my amazing colleagues, Dr. Shrelo and Dr. Mahadevan, worked closely with our team at Digital Medic to produce the COVID-19 training for healthcare workers course. So this course consists of a number of short modules on identifying the symptoms of COVID-19, describing its natural course, diagnostic modalities, and escalating treatment strategies when caring for patients with COVID-19 disease. The course was made available on 2 major MOOC platforms, Coursera and edX. The course was initially produced in English, and we have since produced Spanish and Hindi versions, while other languages are currently in development, including Portuguese. We have had terrific engagement in the course as we approach nearly 100,000 users. Notably, we have had significantly higher than average completion rates, with about 20% of enrollees actually completing the course. Given this high completion rate, we wanted to look at what might be motivating factors in learners' decisions to enroll in and complete the course. Specifically, we were interested to see if offering a certificate of completion was a strong motivating factor. And we additionally wanted to see if there were differences among different types of healthcare professionals, i.e. nurses or physicians. In December of 2020, I wrote a 20 question survey that was sent out to all of the participants who completed the course. The survey was additionally added to the end of the course, so new participants were given the option to complete the survey upon course completion. The results I'm going to show you were pulled in February of 2021, so we do plan to pull this data again in the near future. So from this data pulled in February, just over 13,000 people were contacted, and about 20% of those people completed the survey. On this first table, you can see some of the survey participant demographics. You'll note that our survey respondents tended to be younger than 40, with more female respondents than male. Generally, we had a good distribution of educational level and healthcare professions, with broad geographic distribution worldwide, though notably the majority was from North America. Finally, you can see that nearly half of our respondents were from high-income countries. This next table describes the context in which our course completers were working. We had hypothesized that maybe the course participants would be people who deemed themselves to be the last line of defense, so to speak, which is why we asked this question about physician availability. But it seems that less than 25% of respondents worked without a physician available in person. And of that group, only 18% didn't have a physician available by phone. As this was much earlier in the pandemic, less than half of our respondents were working with COVID-19 patients already, but almost 90% of respondents anticipated that they would in the future. This graph shows the motivations for taking the course ranked in order of importance to participants. The clear winner you can see here is to improve practice and personal learning. But you can also see that certificates play a significant role. That's this color here. And so one is that their primary importance and decreasing importance going to the right. This table shows that the majority of participants chose to obtain the certificate. Nearly 60% provided the certificate to their employers, and 65% plan to use the certificate for continuing education requirements. Our survey had a free response section, and I thought this quote nicely highlighted learner perception of the certificate. Certification helps employers evaluate potential new hires, analyze job performance, evaluate employees, select contractors, market services, and motivate employees to enhance their skills and knowledge. Certification gives recognition of competency, shows commitment to the profession, and helps with job advancement. And over here on the left, you can see my actual certificate for completing the course. The Open WHO also offers a variety of COVID-19 online courses. Many of these courses are targeted to the general public, but several are more healthcare worker specific, namely the 6 I have listed here. For the past few months, we have been collaborating with the Open WHO to survey their course participants. The Open WHO platform has a broader global reach in both sheer numbers of learners and also reaching more learners in low and middle income countries. A few weeks ago, we sent out an adapted version of my initial survey to the participants from these 6 courses, and we've already gathered about 5,000 responses. From this data, we plan to perform a comparative analysis of our 2 data sets with aims to further describe the learner population of enrollees in public health emergency MOOCs. We would like to see what countries and what country income levels participate most commonly to determine if there is an absence of participation in low income countries, as we hypothesize there might be. Further studies could potentially identify the barriers in these locations so that they may be addressed. We also hope to discover participants' motivations for enrollment, comparing them across healthcare profession type and context. Finally, we want to see if and how learners are using the course certificates in their professions and to determine if certificates add significant value to the course. We think this descriptive analysis will help inform the development of future health education MOOCs, allowing us to cater to our learners' needs more appropriately. There are a few of my references. I'd also like to acknowledge Jamie Johnston, who has been an invaluable collaborator in this research project as well. Thank you for your attention. I'm happy to answer any questions.
Excellent. Thank you so much, Jennifer Jones, for finishing right on time. So move on to the next speaker. Amity Elias, are you in? I've been trying to track her. Is Amity Elias in? She's the next presenter. I don't think so. Okay, thank you very much. So I'll hand over to my co-moderator to introduce the next speaker, Midion Mapfumo Chidzonga. Over to you to introduce the 4th speaker.
Thank you very much, Prisca. I'm sorry I got in a bit late. I was having difficulty
It's right. Thank you.
With connections. Right. The next speaker on our program is Machoka Kanairwa. Are you in, Kandio? Is Machoka in? Hello? It would appear we don't have Machoka as well. Sorry. Yeah. So is there any way we can, let me look at the...
I'm checking through the panelist list and there's no, it's not in.
Okay, and then that's who. Then the next one is Hadija Semvua.
Hadija.
I'm trying to look at the list of participants, whether they are there or not.
Yes, I'm checking. Hadija is also not here.
Oh dear, that's the end of the day, isn't it?
Oh, that gives us room to explore the 2 speakers. If
Yes.
they want to say any other thing, or if they want us to take their questions. Okay, Hadija is not in, and Machoka is not in, and Amity Elias also not in. Okay,
so
thank you.
The other presenters maybe can, especially the first one, I think didn't finish their presentation. Maybe they can be given time to finish it off, because we put all the time in our hands.
Okay, Jamie Johnston and her partner, do you want us to take a few minutes more to elaborate on anything you did not quite finish well because of time management? I apologize once again.
No problem, actually. I think we were mostly finished with the presentation. I think Nokiwe was able to share kind of our takeaway from the study, but really the thing that we took away from the study is that although we didn't see differences between the treatment and control, so we didn't necessarily see higher breastfeeding rates or higher rates of safe infant feeding practices in the treatment group, we did see that they were comparable to that of the face-to-face. And the time tracking data and the qualitative data on the experiences of the mentor mothers may suggest that there's efficiency gains to giving community health workers educational tools like these to be able to aid in their work, to be able to bring legitimacy to their work, to be able to communicate with clients. And so we do see that as a positive of the intervention itself. What we really want to study in future studies is the use of these types of tools in areas where we don't necessarily have these very highly skilled, highly trained community health workers. Palani is kind of a gold standard in terms of the support that they give to the mentor mothers and the training that the mentor mothers receive. But we know that this isn't the case globally and across South Africa even as well. And so if we can get tools like this into the hands of community health workers who are perhaps more novice or don't have that type of training, we may actually see some improved or even higher outcomes in terms of the results of the effectiveness of the intervention. So yeah, we really thank you for the time to be able to share our findings, and we would welcome any questions you might have.
Thank you so much. Appreciate it. And let me call on Jennifer Jones to also add on to the presentation, if she has any other thing to add before we open the question.
No, I'm finished, but I'm happy to answer any questions anyone has.
Okay, thank you so much. And so I'm going to turn it over to the Q&A session. I've actually been checking along the line and I didn't see any question. So I'm back to check and I have no questions.
No questions.
Yeah. So from the chat, I'm just trying to see. So it's been communication between me and the panel members. Okay, that's awesome. Thank you. The media people, are you fine?
Yeah, I'm fine. I'm okay. Okay,
thank you so much. We have some minutes on our hands, and maybe we can just dialogue. I would like Jennifer to talk about the open online course enrollment among the healthcare workers briefly. When you conducted this, I saw a particular slide that talked about the WHO involvement. I didn't quite get that. Do you mind to explain further on that WHO section and the online online teachings that WHO embarked upon, or is it you that talked about, for example, you gave hand hygiene, online course on hand hygiene as an example, and then I want to know the utility of this across Africa. Thank you.
Sure. So the Open WHO actually has, I think, more than 10 courses about COVID-19, and they're very short modules, some of them from like 20 minutes to a couple hours, and they focus on different topics within COVID-19. So some of them are more directed towards healthcare professionals than others, and some of them are more targeted towards generally like the general public, vaccination awareness, that kind of thing. And then they have even ones that are more targeted towards like how to set up a healthcare like testing system. And so these 6 courses were chosen by the group that we're working with at the Open WHO as courses that had content more targeted towards healthcare workers. And so that's why we chose to use those courses to compare the data that they obtained we sent the same survey basically to that that course participants so that we can compare the data. So we actually haven't seen this data yet. It's still being collected, but we wanted to compare because we thought that the Open WHO had a broader reach in terms of how many healthcare workers they're accessing. They've been around a little bit longer, and so they already have a very large base of participants that take other Open WHO courses, not just related to COVID-19. And so we were hoping that we could get more data, essentially, by sending out the survey to their participants, which it seems that we have. They've reached a lot greater number of people just in a couple weeks than we did over the several months. And so in terms of the comparison, we're also hoping that they have a greater reach in low and middle income countries. We're not 100% sure on that yet because we haven't seen the data, but we do anticipate that they may be reaching more of the low middle income countries than the actual low income countries. But we think that data will help us determine how we can best target future courses to people in those countries. Does that answer your question?
Yeah, absolutely. Thank you so much, Jennifer Jones. Appreciate it. I have a question for Jamie Johnston by an anonymous attendee, and the question goes thus. In this study with the mothers and breastfeeding, were all the mothers literate? Was there any exploration of how it impacted illiterate mothers' training? Thank you. Over to you, Jamie Johnston.
That's really a wonderful, excellent question, because we did wonder whether or not video education would help overcome some of the literacy challenges. In terms of the mothers themselves, I can let Nopiwe speak to this a bit more, but looking at their characteristics, a number of them were in fact educated at least and had a secondary degree. And let me pull up the, so at least 55.7% of the mothers, so over 50% had at least some secondary education, and 40% had completed secondary education or more. So these mothers were, for the most part, at least receiving some secondary education. Nopiwe, you may be able to say something more about the literacy rates. We didn't actually look at the differences because so many of the mothers were educated with a secondary degree. We didn't look at the differences in the outcomes based on this characteristic, but it's an excellent point that we should follow up on.
Yeah, so when Jamie is saying secondary, we're meaning secondary school. So if we're speaking literacy, yes, they are literate, but also remember eligibility criteria said the person must have worked with Philani for at least more than 6 months. Philani, this is where the Mentor Mothers, the organization is called Philani, actually conducts regular trainings with Mentor Mothers monthly, even actually. I've seen trainings run 3 times in a month for different health topics. So we know for a fact that they are used to reading, they receive manuals, they receive training manuals, they receive pamphlets, and these are tools that they use to educate clients. So we know that they are literate, and particularly literate within the jargon of health and the community health work that they do. We did not explore illiterate mentor mothers. Also, I do wonder if Philani would have those, because how they do run their business is that they conduct trainings regularly, which requires reading and writing reports and writing, registering clients and conducting follow-up, which also requires a lot of paperwork. As we see from a mentor mother quoting that, there's a lot of paperwork to do. I appreciated the fact that I could talk to a client, I could give them a video to watch, and then finish completing writing in the documents. So we do know that all the mentor mothers essentially are literate. So no, we did not test among illiterate groups. That would be very interesting though.
And Nopiwe, could you speak quickly to the literacy rates of the mothers themselves?
Yeah, so I mean, Philani mentor mothers access a lot of their population. I think we saw the variety of the age groups in which they are located. So it is young moms. A lot of them will have completed some mostly primary school education, and many of them will have completed high school. But we definitely not a lot of them will have completed tertiary education. Those are kind of the literacy rates we find in townships in South Africa. So mainly some secondary education, a lot of high school education not completed, and very few having completed tertiary education.
And I just took the liberty of sharing the slide where we describe the education rates of the mothers themselves.
Oh.
If any one of us attended the panel session in the morning, there was talk of community. So how would you describe the mothers you were dealing with, since they're all highly educated? So what community is that?
Sorry, can you repeat that question for me?
Early in the morning, there was the plenary session, there were discussion on what is a community when we're talking of health. And so my question would be, since you chose those who are literate, who have done some secondary education, what kind of community is that?
Okay, so I think we're speaking of two people. There's the mentor mother, who is the community health worker. We started classifying their literacy rate because we were trying to explain whether these are literate people or not. And then we spoke about their clients and what the clients that they serve, what their literacy rates look like. Am I still understanding you clearly?
Yes, okay. So in other words, the mothers were at all levels of literacy in terms of illiterate and literate. The mothers' education level.
So the clients that are being served by mentor mothers. Yes, they are at all levels. These are mothers in. So as we showed the characteristics of how we randomized, these would be people who live in different settlements. Khayelitsha, as a whole, is a peri-urban area. It's a township in South Africa, so a classic township, right? So there you would find people who are living in different, let's say it's a mixed environment. However, so the mentor mothers assist any client in their area. So mentor mothers also lived in that mixed area as well. So we could say that their clients are mixed, but by virtue of Khayelitsha being a highly adverse area and being a classic South African township, we know that they are not, we probably did not have literacy rates to the extent of having a university education.
Okay. And the video is in what language? Local language, English, or what? Yes.
So the local languages spoken in South Africa, in Khayelitsha, Cape Town area particularly, is Afrikaans, English, and isiXhosa. We had our videos in those languages as well. We did find that a lot of clients did prefer watching the videos in their native language. So another language that they loved very much is English. But strange enough, when doing learning with mentor mothers, they preferred watching the videos and understanding the content in English, which makes sense because most of our training is in English. So we kind of make sense of our work in English. But yes, a lot of languages, a lot of videos were watched in mainly English and isiXhosa, the local language.
Okay, thank you very much.
Oh. Thank you so much, Midion, for all those questions. And I think none of those presenters have sent a message. So just want to appreciate the two speakers and to say this is awesome. I mean, good for you. You have all the time to attend to all the questions and made it very clear to us in your presentation. I want to appreciate you and say thank you very much for the wonderful presentations you've made and for taking on this time to be able to expatiate on the question that was asked by the anonymous attendee. And all the participants in this session are greatly appreciated. Thank you so much for making it here, and please keep safe. The topic that we have looked at is research approaches to assess impact and quality improvement in health education. We have had Johnston and her partner, as well as Jennifer Jones, who has spoken with us on cluster randomized control trial of a community-based mobile video breastfeeding intervention in Khayelitsha, South Africa. And that's been awesome. Thank you so much. We also had Jennifer Jones, who spoke with us on investigating the role of certification in massive open online course enrollment among healthcare workers. And a big thank you. Before I let you go, I want to ask for the category of healthcare workers who were involved in this open online course. And I also want to find out this certification, to what extent, what is the importance of this certificate that people are given, the healthcare workers receive at the end of the training? Do you find that this certificate is going to really motivate and encourage people to want to engage on this massive open online course? Is it in any way improved or suggested that without a certification involvement, the turnout may not be as expected or as you had. So as I stop, I will ask you to just take on that. I mean, Jennifer Jones, just take on that while we wrap up the session. We have just 5 minutes more. So within the 5 remaining minutes, let me just have you, Jennifer Jones, talk about that, and then we'll be closing. Thank you. Over to you, Jennifer Jones, if you heard my question and you want to respond to that.
Yeah, sure. So the first part of the question was what kind of healthcare workers? I only have the data for the Stanford course at this time, but we had about a quarter of the healthcare workers were physicians, 16% were nurses, 27% were other healthcare workers, but we also had a bunch of subcategories like student, public health worker, we even had pharmacists, and other types of healthcare workers who enrolled in the course. And there was a free text option as well, so people could put any type of profession in there. In terms of the certification, that's kind of the whole object of the study, was to see how people are using the certificate and how they value it. So from the initial, the preliminary data, we don't feel that it's like the #1 motivating reason that people take the course, which is kind of what we were expecting. We figured people would be taking it for their own personal learning, or because it was mandated by an employer. But we did want to see if it was like a determining factor for some people, and then how they would use it. So we plan to actually take the data and break it down and do subgroup analysis to see if there's differences in motivations between different types of healthcare workers. So for example, one hypothesis is that like in at least in the United States, physicians have to do a certain number of continuing medical education requirements per year to maintain their physician license. And nurses have different types of requirements that are somewhat similar. And so we were curious to see if people would be using this course to fulfill those requirements, and thus would need the certification to do that. We also were curious to see if that would differ based on countries, because every country has different continuing education requirements for their different healthcare profession types. So I don't have the answer to the question yet, but we are investigating it. And then we also wanted to see if the certificates were being used to give to employers. So one of the questions that was on the survey was, did you give this to your employer? And did your employer reimburse you the cost of the course? So one of the edX platform that we had the course on, you could take the course for free, but if you wanted to get the certificate, there was a $10 fee. And so we wanted to see if employers were reimbursing the cost of the certificate. That would probably improve motivation for taking the course if someone else was paying for it. So those are still, like, that's a very good question. That is the purpose of the research that we're doing, but we still need to analyze the data to find out a more precise answer.
Thank you so much. Appreciate it. Just a comment from me. In Nigeria, we had that kind of training, and I anchored that for 8 countries in Africa, and it was purely among nurses. And one of the obstacles we had is getting a CME, because the regulatory body for nursing in Nigeria decided what kind of program they want to allow for the accreditation process. And when we were done, we didn't quite, underwent the training, the protocol. And so we had lots and lots of difficulty ensuring that the participants were able to make use of that to count for them as a CME. And that was a big problem for the participants. And it was a lesson learned for us to make sure that we pass through the protocol and we ensure that it's going to count for CME for the participants. It's a very strong motivating factor and a predictive factor if we are going to run that training again, if you're going to have people enroll, for that kind of training. So that's why I asked that question, and I appreciate your response. Thank you very much. I have a question from the chat. It was not placed in the Q&A session, so let me quickly ask it. And it's about this short course. Somebody wanted to know how people can register for the COVID-19 short courses. They want to know. Okay, somebody just has answered. You can go to the Coursera website, find the course and click enroll. I actually enrolled for about 2 of the online courses myself. I went through Coursera website and I enrolled for management and 1 other course on genetic counseling, and I did it and I got my certificate at the end. So it was quite interesting. So that answer has been provided by Jenny Jones. If you look at on the chat form, you will just find the answer there that says you can go to the course webinar website, find the course and click enroll. Thank you. Somebody wanted to know if you are going to share the presentation. Yes, it's going to be available at the AfriHealth website at the end of the whole conference. So I believe that has answered that question from Makatello, Mohasi, and Amanda, Miss Duana. Thank you very much. If there's no other question, I will just be wrapping up. Does anybody want to say anything? Do you have any comments, any question? Likewise, the Open WHO website is easy to navigate to enroll in their courses. Thank you, Jenny Jones, for that additional information. So apart from going to, oh, wonderful, you have just done what I was going to ask. That can we have the link? So the distinguished attendees, Jamie Johnston has actually provided for us the link to the online course. So you just go click on this and then here you go. What a very important benefit of attending this conference. Thank you so much. So we have these 2 great presenters, 3 actually, because Jamie Johnston actually had a partner who joined in the presentation. Thank you so much, Nufiwe Job, for joining Jamie Johnston in your presentation, and a very wonderful thanks to Jennifer Jones as well for her presentation. So Miss Amanda Dana is just saying thanks to Miss Jones, and big thank you. I want to thank the attendees. Thank you so much for your interest in the presentations that we had. Thank you so much for being present, and thank God that your network allowed you. We appreciate it a great deal. And I want to thank my co-moderator, who I am going to give the opportunity to introduce himself, because it was not in when we started. Over to you, Midion.
Thank you very much, Prisca. My name is Midion Chidzonga. I'm with the University of Zimbabwe, an oral and maxillofacial surgeon, former dean of the College of Health Sciences. I'm sorry I couldn't make it on time. I came in late. Thank you very much, the presenters, for the hard work, and keep it up. This is research, and this is what we are looking for. Thank you very much.
Thank you so very much, Midion, and thank you so very much, all the presenters, all the attendees. We appreciate you. Once again, my name is Prisca Adejumo from the University of Ibadan, Department of Nursing, Nigeria. Thank you so much for being with us. And let me hand it over to the media crew to say a word.
I'm told we are supposed to put on our video so that they can take a photograph or something like that.
Oh, okay. Media, can you please help us with that? Let's show our video. Oh, you know, it says it's unable to start video. Media, can you help us? We have just 1 minute more.
Yeah, that's for the media. Okay.
Media, can you help us?
You can start your video.
It says you cannot start your video because the host has stopped it.
I know. Because they had said they are supposed to take it for records purposes. I don't know, maybe we won't be recorded.
Let us try. Try to remove your, to start your video. Can we start it?
You cannot, apparently.
Media for AfriHealth, are you in? I can see them. Media for AfriHealth.
Nope.
Okay, maybe they left us when we started, but they were here actually, and they assisted in locating Nufiwe Job when I was trying to locate her. Maybe because actually we have 1 minute more. It's 2:45 to 3:45, and this is 3:44, so they are supposed to still be here. Let me just send a chat. Hi, your attention is needed.
Nope.
I have just sent a message and say, hi, your attention is needed.
Yes, we've done that.
All right.
What did you say?
You have made your co-host, the two moderators. You have made all of your co-hosts, so you can turn on your videos now.
Okay, please go ahead and turn your video.
Okay, mine
Thank
is
you
on
so
now.
much. Yeah.
Hi, how
Thank
are
you.
you?
So, who is taking the
Let us-
photograph? Jamie Johnston, you are here to turn on your video?
I'm still unable to. I still have the.
I've done mine. Oh, good.
Nobody was done. Hi.
Hi.